Thank you, Dr. Yodi. We needed a spark. We needed inspiration. Did we get it? I think we did. This panel focuses on a number of issues that Dr. Yodi was just talking about, bringing together politics and the technical expertise, bringing together a lot of the questions that were stimulated by her introduction. Over to you, Vanessa.
Thank you for the call to accountability, because that's ultimately what I think this whole week has got to be about, is how do we change what has been a lot of talk into absolute action. And I'm actually incredibly privileged to have a power-packed panel here that is going to help us talk about that. And I'm going to put you in the hot seat about how we transform this into action. So I'm going to take a quick moment to introduce our panel, and then we'll ask you all a question that I will ask you to respond in turn. But we have with us today Dr. Ahmed Ogwell Ouma, who is the Acting Director of the Africa CDC, and it's a pleasure to have you here. We have the Minister of Health from Burkina Faso. We have Minister Kargougou. We have, I don't want to forget anyone's names, we have Dr. Atul Gawande, who is the Assistant Administrator for Global Health at USAID. We have Dr. Monique Vledder, the Head of Secretariat for the Global Financing Facility for Women, Children and Adolescent Health. And then we also have Priya Basu, who's the Head of the Secretariat for the Pandemic Prevention, Preparedness, and Response Fund, and the Head of the COVID-19 Taskforce at the World Bank. So what we really have on here is a bunch of people who can actually make action, make policy, make change through the conversations you have, the decisions you can help make. And I'm excited to ask you about this a little bit. So I'm going to ask you each the same question, and I will ask you to reply. We are now talking, as we've come out of COVID, and 180,000 healthcare workers have died as of November of last year. We have, as we heard, a lot of applause and not a huge amount of payment or protection always. And so all of you are thinking about this and working for this, and there's new health workforce initiatives or mechanisms that you are all leading. How will these support the health workers, including through education, or recruitment, protection, fair pay, retention, career advancement, or gender equity? And Dr. Ahmed, I'm going to ask you, please, to respond first.
Thanks, Vanessa. Good afternoon. Some of us, our minds are in the middle of the night wherever we've come from. So forgive us if we get lost a bit. I think, let me start by thanking Yodi for making it very difficult to have another conversation after that very clear message. And to pick up from where she left, and in an attempt to answer your question, Vanessa, is to say at Africa CDC and the Africa Union, if there are lessons that we've learned, is that talking is good, but talking only is bad. It's better you don't talk at all if you're not going to implement anything. And so for us, we have taken the path of we begin actual action in addressing the issues around health workers, and we have several initiatives. I'll not go through all of those, but I would like to speak on only two. One is we have been tasked by the Africa Union Assembly of Heads of States to, by the end of 2024, to have at least 2 million community health workers paid out there engaging with the communities to ensure that the public are receiving good information and the public are receiving appropriate care where it is necessary. So we have that target we are chasing, and we think we should be able to meet that target. So that is an active item on our agenda. Second is the huge gap in leadership in public health. Many in Africa come into public health leadership literally by accident. You come from medical school, you're thrown into a district somewhere, and you're asked to run the district. The only education you have is clinical medicine. Nobody told you there's something called a balance sheet and there are procurement processes, nothing. Woe be unto you if you're a lady and you're out there. It's even worse. So as Africa CDC, we have put in place several initiatives for leadership in public health, the most famous of which is the Kofi Annan Global Health Leadership Program, where we are actually actively training. We are on to the second cohort now. The third cohort will begin at the end of the year. We are giving skills and appropriate exposure for leadership in global health. And our cohorts are always 50-50 female-male, except this second cohort where the females were more than the male. We are just about to begin another leadership program, which is strictly for young women in health, strictly young women in health, so that we can be able to expose as many as possible to leadership, and that way we secure health from a leadership perspective and not only from a service perspective. The last thing I would like to say is this area, the only way to do it is to go local. We must get our governments to allocate adequate resources into the health sector. We have the Abuja Declaration of 15%, not implemented very well in most countries. But apart from that, we must get domestic resources to do more for health. Private sector are doing business in our countries, earning huge amounts of profit. They must give back. It should not be an option. It should be an obligation. We are paying taxes, so our governments need to also take responsibility in these areas. So if we don't get domestic resources to speak to, plan with, and deliver on providing opportunity for healthcare workers to be adequately remunerated and motivated, then all this will again end up with being talk. But at Africa CDC, the Africa Union, we have clear targets, and we are keeping to those targets so that we can be able to deliver by 2024 for community health workers and for leadership. Every year, we want to make sure that we get the best to join our programs for leadership and ensure that when they go back out there, they're actually doing what we are talking about, but they will be doing it at country level to ensure that Africa remains with some semblance of leadership. Now, for those we have trained, please don't poach them, you international organizations. Leave them for us in Africa so that we can be able to make a difference. Thank you.
Thank you. I'm going to actually ask Dr. Vledder to answer the same question. Tell us a little bit, please, about the initiatives.
Great, thank you very much. I'm honored to be on this distinguished panel. I wanted to have a special greeting to the Honorable Minister of Health from Burkina Faso. Maybe briefly, I'll start with saying that the Global Financing Facility was established in 2014 to improve the health and well-being of women, children, and adolescents through the scale-up of community-based primary care services and addressing health system bottlenecks like human resources for health and looking at long-term financing from domestic sources. And all of that to improve, as I said, the health and well-being of women and children. So when we look at the 38 current partner countries, there are many examples of countries that have done quite well in scaling of innovations on human resources. For example, Rwanda used the GFF investment case to provide incentives to move health workers to underserved rural areas. In Indonesia, they prioritized the national scale-up of human development, community-based workers, particularly to look at the severe issues around malnutrition. And in Ethiopia, the engagement with GFF was used to scale up the successful extension worker to particularly look at underserved rural areas and increase the capacity. So these are all examples of successful programs that we can further build on. There are 4 things going forward that I think are the priority. Number one is that country leadership is core. It's really at the country level where decision-making takes place, and integration of any kind of technical assistance or support should take place under country leadership. Number two, we have an opportunity to look critically, based on evidence, what are the national priorities to invest in human resources, and how do we ensure that we align our support and our engagement around those country priorities. Number three is we need financing at scale, and my colleague over here already said it. This is, at the core of this is domestic funding. The majority of funding for human resources for health comes from domestic sources. So how do we ensure that these are good investments, that they're based on evidence, and that they are efficient and achieve the expected results? And finally, coordination. And so we're really excited about working together with USAID and other agencies, including civil society, to collectively improve on this really important agenda. Thank you.
And I don't have COVID, I have reflux. So my apologies as I'm sitting here hanging, but thank you for that. And I think it's a wonderful series of interventions. Dr. Gawande, I'm going to ask you to tell us a little bit about the interventions the U.S. government are doing for the workforce. And I want you to lean into some details for us, please.
Yes, ma'am. You do what Dr. Kerry says. So I want to put this in a little bit of context. We have had 40 years of promising to do something in primary healthcare. And that mobilization of resources that we're all talking about hasn't happened with confidence and at that level of scale that we have been seeking. I think part of the significant change in the last year in the Biden administration has been to shift from a focus on investing in primary healthcare systems to investing in primary healthcare workers. And the reason that is significant is that the workers, the people, are your best indication of the function of the system. And so I want to dig into a little bit more detail around that. We have had a long partnership, for example, in Ghana. We've had partnership across many countries in Africa, Latin America, Asia, in enabling and strengthening primary healthcare systems. But in Ghana, starting in the 1990s, with what's known as the Navrongo experiment, they demonstrated what the investments in health workers needs to be. And that was showing that investing in community health workers and making sure they're salaried, not volunteer, making sure that those salaries are paid on time, which is not often done, and then that they have adequate levels of training. 12 months is what they 18 months was demonstrated in Ghana. Other places I've seen have done it 12 months. But when you're down to 3 or 4 months, that's not adequate training to deliver on a very wide package of capabilities. Then they have to have the medicines and the diagnostics enabling those basic capabilities that they bring. And critically, they have to be integrated into a primary healthcare system, a primary healthcare clinic where they have a direct relationship because they are in the communities they're touching. Many of you are touching every home and seeing not just the child that you're equipped to take care of a malaria diagnosis and treatment or a prenatal set of care and vitamins, or some immunizations, but also to recognize the person with diabetes, the person who has a problem, the fever that's not going away with what you attempted to provide, someone who has a complicated pregnancy, and seeing that they can get to that next level of care. So when that was invested in Ghana, they could demonstrate a 50% reduction in mortality in 3 years. This was in a randomized trial, the highest gold standard demonstration, and at 7 years, a 70% reduction in child mortality. Those elements, I think, unlock the key. Over the first 20 years, or last 20 years of making investments in public health, we've been able to leverage much larger dollars by demonstrating in individual diseases that you could have clear metrics and deliver on them. And that's why there's been confidence in making the investments at extraordinary levels. Global Fund here to raise $18 billion for HIV, malaria, TB. The President Biden has made a commitment to raise $1 billion, has sought $1 billion over 5 years from Congress. That's a fraction of what we're putting in. We're putting in $2 billion a year for those 3 diseases. It's $1 billion over 5 years, and there's no appetite on the Hill that we're seeing to actually pass it yet. Many folks here, including David, are up and pushing for that. And it's because we have not demonstrated how it will generate the impact that we want to. But I think we have the formula where if you can demonstrate that we're increasing the number who are salaried, the number who are paid on time, the number who are trained, the number who are integrated into a primary health clinic, that we can see the outcomes and demonstrate that the investments end up having a payback that can matter. Finally, I'll say, this is work that takes years, decades. Our political leadership changes much faster than that in high-income countries, middle-income countries, low-income countries. And what has made it work is civil society, NGOs, organizations that keep pushing over all of that time against a coordinated set of goals and ideas that really matter. And that's why I think that the final thing I'll say is that leadership like the Global Finance Facility, what the World Bank has been doing, Africa CDC, coalescing around the health worker, demonstrating that we can increase by clear targets, 2 million paid workers, that we can demonstrate that we have what level of progress we're achieving in different countries and how that changes life expectancy and the outcomes for folks. I think that represents the pathway forward. And this language, this approach, that commitment, I think has really only been there for the last year. That said, we have been doing it as we've been going along for the last decades. We've seen the results. We just haven't garnered the level of financing we will. Finally, I'll just say, I was in Nigeria earlier this year for a review of some of the health worker investments and with Gavi. And what was striking was that they had seen a marked increase in the dollars going to healthcare, marked increase in the dollars, percentage of those dollars going to primary healthcare, and in 3 states out of 35, it had a remarkable bump up in everything from routine immunization to other kinds of outcomes. The difference between those 3 states and the other 30-plus states was that those workers were paid on time. When I was there were worker strikes because many in the other states had not been paid on time for up to 6 months without pay. But when the technical support was there to ensure that the budgetary capability and the problem solving to get the budgets out the door fast enough, that meant the medicines were there, the diagnostics were there, and the workers were paid, without changing how much money went into the system. And that's why some of these considerations are really crucial and can be acted on now.
Thank you. Ms. Basu, I'm going to turn to you, please. I would love to hear, and Atul, I am going to come back to you, so you're not totally off the hook yet. But I would love to hear from you about the interventions that you're hoping to lead.
Thank you very much. It's an honor to be on this panel today. Thank you so much for the invitation, David and colleagues. So in a way, the new Financial Intermediary Fund on Pandemic Prevention, Preparedness and Response that was literally just launched on the 8th of September is the newest kid on the block. And I'm very happy to introduce this fund to you. In fact, this is the first time we're actually talking about the fund since it was formally launched a couple of weeks ago. It's been a work in progress for about 9 months now, and it is the product of a long-drawn consultative process that has involved governments from around the world, civil society organizations, multilateral banks, UN organizations, the sort of leading global health organizations. It was discussed in detail within the G20, led by first the Italian presidency and then the Indonesian presidency, and it was kind of debated in a lot of detail. We put out a white paper in May and got a lot of comments from civil society. And I hope that we've been able to factor in all of that into the design of the fund that was announced a couple of weeks ago. We've already mobilized $1.4 billion thanks to the generosity of 22 donors, but we're not stopping there. We're looking for a lot more because as you've heard already, the needs are enormous. This is the first ever dedicated financing mechanism focused on pandemic prevention, preparedness, and response. Obviously, it's coming out of the learnings from COVID, but also from past pandemics. I think it's not a controversial point to make that we've seen pandemics come and go, and we've seen cycles of panic, and then we've seen cycles of neglect. Every time there's a pandemic, from avian influenza to SARS to MERS to Ebola to Zika to COVID, there's public attention on pandemics, but then the next crisis hits us, and maybe it's a food crisis, maybe it's it's an energy crisis, maybe it's some other kind of crisis, and the world's attention turns away from pandemic investment to investments in other things. So this initiative is very much focused on trying to keep a strong eye on the investments that are needed, the intergenerational investments, the long-term investments that are needed to really prepare low-income countries and middle-income countries for the next global health crisis. And as my colleagues in WHO say, it's not if, it's when the next crisis will hit. In terms of the objectives of this financial intermediary fund, and we do need to find a new name for it, so any ideas welcome. It's really a mouthful, but the objectives of it really are to prepare low-income and middle-income countries for the next pandemic, but also to work on pandemic prevention and to make sure that the chances of a pandemic sort of are reduced. But then, when a pandemic does hit, the countries are well prepared to cope with it. And central to this is really strengthening health workforce capacity. As has already been said, a strong, resilient, agile, adaptable health workforce really is the cornerstone of health systems and critical to helping an effective response to the next global health crisis. But the fund will also focus on investments in disease surveillance, in labs, in community engagement, in emergency coordination and management, investments in strengthening capacity at the regional level and global level for investments in vaccines, therapeutics, diagnostics, other essential medical countermeasures to make sure that we don't face the kind of inequities in access that we faced in the wake of COVID. So really to make the investments now to ensure that there is affordable, equitable access to key medical countermeasures. And some of the key principles on which this financial intermediary fund is based is, one, to complement existing institutions. So it's not a new institution. It's not the idea is not to create some new global health entity which will compete with the existing ones. It's really meant as a financing vehicle that will channel resources through the range of existing institutions that are involved in the PPR space. So working in a complementary way, also to promote coordination across the existing institutions and really serve as an integrator. So at the country level, for example, there are these national action plans for health security. We would like to use the FIF to fund those plans, but in a way that brings together all of the different partners at the country level who are working on this area to come together in support of a national action plan. So we're hoping that one of the ways in which we will be able to sift good proposals from less good ones is proposals that can really show that there's coordination around these country-level plans. We really want this to be a country-led, country-driven type of financing model. We also want to use every dollar of the grant financing, and it's purely grant-based, that this fund provides, to incentivize countries to invest more. As was mentioned, domestic investments need to be scaled up. I mean, we've done at the World Bank studies with the WHO that have shown that about $30 billion of additional investment is needed per year over the next 5 years to strengthen pandemic prevention preparedness in low and middle income countries. Well, 2/3 of that has to come from domestic investments and 1/3 from external. So every dollar of the external grant funding that we provide, we hope will incentivize countries to make sustainable investments. We're also kind of very conscious of inclusivity and agility, and these are not necessarily competing priorities, but we want to make sure that voices are heard in the decisions that are made. That's why we have CSOs as voting members on our board. We have an equal balance between representation from high-income countries and middle-income countries on the board. We see this as kind of a platform for advocacy as well, on top of financing. Transparency and accountability are critical. So, and we're right now, as we speak, so we've gotten the fund up and running, but we're now working on, the kinds of criteria for funding. We will be issuing a call for proposals in November, so stay tuned, and we do hope that, this fund can be one way. It's not the solution, it's just part of the solution, but that it can provide the financing that's needed to strengthen your capacity in low and middle income countries to face the next pandemic, and health workforce capacity is a critical dimension. So
Thank you. You've answered the upcoming question for me in some ways too. But before we get there, I want to ask the Honorable Minister from Burkina Faso, if you could tell us, please, about the interventions that you are leading in your country and how you've been working with some of these partners to transform the workforce in Burkina Faso.
Thank you very much. It is really a pleasure for me to be part of this panel, and I just wanted to apologize as I am a French native and my English level is not very good. So before going forward, let me give you a big picture of Burkina Faso context. As perhaps you may know, Burkina Faso is facing a difficult security situation with a humanitarian situation which is very difficult. 1.5 million of internal displaced persons and many areas where government services are not available. So with this situation, we are really focused on primary health care with a focus on community health. And so, which is really important for us now is to ensure that the 17,000 of community health workers that have been hired since 2016 are well trained, are regularly paid, and regularly supervised in order to allow them to deliver integrated package on health and nutrition for vulnerable people. So this is our one priority. And we also wanted to expand these community health workers because we are aware that 17,000 community health workers are not able to give health in all the country with more efficacy. Secondly, we want to reinforce the training of general practitioners in surgery, in essential surgery. For example, I am an example of this training. I am a general practitioner and I have been trained in essential surgery, which allowed me 20 years ago to make operations in rural districts. So we want to reinforce this training in order to allow rural people to benefit from health. We also wanted to put in place a sort of arena for health workers who are in insecurity areas. These health workers often work with high pressure. They are always obliged to deliver healthcare to terrorists. So for us, it is important to put in place a sort of arena mechanism which will allow them, after having worked 2 months, to go to see their families in their country. So it is really important. And the first rotations begin last week. So it is really important for us to put in place and to strengthen this mechanism. We also want to put in place more flexibility in mobility of health workers, because we cannot manage health workers in this situation as we will manage them in a normal situation. Normally in Burkina Faso, if you are a civil servant, if you want to have a chance to change, to have mobility, you should have passed 5 or 6 years in your position before having a chance to be deployed. And so in this situation, we have a fruitful dialogue with my colleague in charge of civil servants, and so we'll have more flexibility to allow health workers who are in the insecurity areas after 2 years to have a chance to have mobility. We are also putting in place strategic purchasing. As you may know, in Burkina Faso, since 2016, we have free healthcare for women and children and under 5 children, and it is the government budget which is paying at the place of population. So we wanted to put in place the strategic purchasing, knowing that if you cannot buy an antenatal care at, let's say, $5 in Ouagadougou at the same price in the Sahel region where insecurity is present. So we think so that if we put in place the strategic purchasing, it could allow to incentivize health workers. We also wanted to put in place some VSAT in these insecurity regions so that health workers could be able to have internet and to catch up with their families. So in Burkina now, these are the domains we are exploring, we are putting in place in order to have health workers in the insecurity regions. And I will finish by saying that it is really important for us to have more alignment of partners. And I wanted to say that Burkina is a part of the Global Financing Facility initiative on alignment. And it is really important for us to have all partners aligned around our priorities. And I want also to say that we want more resources, but more flexible resources. And when I am speaking about more resources, I don't only want to say that we want partners to give us more resources. Yes, we do want that, but the government also is putting more money on the table despite the insecurity situation the country is facing. So thank you.
Thank you so much for that. May I get 2 minutes from you before you go, Dr. Ahmed, who needs to be excused shortly to chair a meeting. I want you, though, from the position of really overseeing these extraordinary programs the Africa CDC is running, what do you need for your partners to be in service to the agenda that you are setting forth and to see it go faster and farther? And if you can take as short as you want, but I need you to answer that, please.
Thank you. The three things that our partners need to do first is align with the priorities of the continent, and by extension, align with the priorities of each and every country, because those, they are a bit different from country to country. So alignment with the priorities is number one. Don't come with your solutions. The solutions are back there in Africa. They will not come from anywhere else. Second is, don't fund one project 100%. It's not helpful. Because if you do that, then the recipient doesn't feel the responsibility of the need to further invest in that particular project. And let's just speak about community health workers. Many on the continent are funded by external partners. And when a crisis comes and the attention shifts, then the community health workers remain with no pay. And this takes us further back because it affects the whole enterprise of community health work. So second, don't fund 100%. There must always be co-investment so that there is a feeling of ownership at the local level. Third is, don't come with short projects. Don't come with short projects. However beautiful the project may be, if it is anything that is less than 5 years, it's not helpful. It raises expectations, and then it kills the local understanding and need for long-term investment. If it is short, please train, and then maybe that's it. But then putting actual active projects on the ground, and then it is for a short time, it's not helpful. It actually takes us backwards. These are the three things that I will be able to say, and I must apologize that we need to run.
Thank you.
Because we are hosting another event. Thank you very much.
Thank you. I'm actually going to come back to you, if it's all right. I want, if you can, this is obviously a big and pretty unprecedented fund that has been created to create that kind of transformative change over time that allows for, to your point, even when the eye drops off the ball, there's somebody there constantly moving that agenda forward. But as we hear a little bit about aligning behind these country priorities, and we hear about the need to fund over time and in the model that our partners are asking for and behind that agenda, even in difficult security situations and things like that, can you elaborate a little bit on how you see this funding coming forth or being awarded, and the ways in which it will be, is it direct to government? Is it going to be through partners? I mean, is there some level to understand a little bit how this is going to be transformative, please?
Sure. So, some of this is, as I said, still being worked out. We have a new board. We're delighted to have, as the board co-chairs, Dr. Ngamije, who's the health minister of Rwanda, and Dr. Chatib Basri, who used to be the finance minister of Indonesia. And we have a very active board that's met once and is going to meet again very soon. I just want to preface my comments by saying that these things are still being discussed. But the idea is that there will be regular calls for proposals, and the proposals will be invited both from countries, i.e., governments of low and middle income countries, and/or from regional organizations, such as the Africa CDC, and/or from implementing entities that are involved in working on pandemic prevention, preparedness, response at the country level. And right now we have 13 kind of initial implementing entities that we're starting off with, which include a range of UN organizations, including WHO, UNICEF, FAO, all of the usual suspects in terms of the multilateral development banks, including the World Bank and the Inter-American Development Bank and the Asian Development Bank and so on, and then Gavi, CEPI, and Global Fund. So there's 13 of those that are kind of initially pre-selected. And so, when we issue the call for proposals, the first call for proposals, it'll become clear in terms of, what kinds of projects we're expecting. But I can say that those projects could be prepared by a country, which may decide, government may decide to invite 3 or 4 major partners that they're working with and say, come together and we'll submit a proposal, so the country could submit a proposal. Or 3 or 4 partners that are already working, or 5 or 6, or however many, could come together with a country and seek financing. So that's likely. So the first call for proposals is likely to be kind of focused on strengthening country capacity. But in the future, there will be other calls for proposals, each of which will seek to meet the needs, and some of them could be around regional capacity building. So, kind of one critical aspect of this is, so these proposals come in, who's going to review them? How are we going to, be able to sift out the good proposals, the ones that are more impactful, likely to be more impactful than the ones that are less, likely to generate the kind of impact we want to see? So in order to do that, we're setting up a technical advisory panel, which will be chaired by the WHO. And so, all of that is kind of happening as I speak. And, clear metrics to be able to measure success over time, and, demonstrate progress. So, stay tuned is all I can say. And we will make sure that, the way it's designed and set up, makes the most sense and, hopefully produces the impact that we want to see.
Thank you for that detail. I really appreciate it. And Dr. Vledder, I'm going to ask you a question. I mean, from your perspective of mobilizing investment and creating, programs and opportunities that are very targeted towards very key demographics and underrepresented and vulnerable populations, how do we mobilize investment, though, from others and in general to work together to have more progress? And how do you see the ability, where does this funding come from to be kind of transformative? I mean, how else can there be a complement to what you are doing? Who else can we motivate to bring funding? Where is this funding for the investments we have to make come from in full? I'm asking you, actually, please. Yes, how do you see this as a partner, Dr. Vledder?
Although she's looking at me.
Although Atul, don't worry, I've got a question for you coming.
He's going to say something brilliant about this.
I have a question for you, Atul, after, and then I'm going to actually the Honourable Minister help us.
Yeah, so we just heard from the new FIF is such a great opportunity, very complementary. We'll make great investments in HOH and beyond. At GFF, we have a little bit of a different model. In the sense that decision-making around funding is made on country level. And so we drive very much the agenda around a national platform led by the government, Ministry of Health and Finance, coordinated and aligned with the partner contributions. And that also allows for, and a colleague from CDC made that point, for the necessary flexibility we need to have. As countries vary quite a lot in terms of what are the most necessary and prioritized investments. And so that country coordination and the decision making, like he said, don't come with the solutions, right? Is a really important part of the GFF model. And in our governance, we work together with Gavi and Global Fund and civil society and all of the bilaterals, including USAID and the UN agencies, to really ensure that at country level this comes together in support of the government's priorities. And then secondly, we need to innovate and think critically around how do we bring scale of financing. And first and foremost, that is through domestic budgets. And so the largest share of investments is coming through domestic budgets. And are we actually giving enough attention to the efficiency, the effectiveness, the focus of those investments? And what can we do to use existing resources better, right? And I'm thinking, for example, on HRH, ghost workers, right? And so when you look critically at many of the partner countries, we see that there's funding that can be used better, in addition to new funding coming in, including from partners. So I'm going to stop here.
It's wonderful, thank you. Atul, if I could ask you, actually, this is a big week for the Global Fund replenishment, and obviously the replenishment is, the US is hosting this week. I'd love to hear from you about what makes you hopeful about the fund in the area of workforce, and how can we help ensure the fund receives the proposals from countries that include strong support for the workforce and health investments? And how do we also maybe help the Global Fund think they've got a very profound platform for community health workers, but one of the things that you have spoken about too is how do we create that referral system and support? So would love to hear a little bit about your take on this, please.
Well, so I'd love to actually also comment a little bit on GFF and FIF as well, while I can get them all squeezed in. I'll say about the Global Fund replenishment. So one of the best things about where we are in the development of our work in HIV, malaria, and TB is recognition of the role of healthcare workers in being able to get this work done. And with John and Kengasong at PEPFAR, he has really come in emphasizing the need to integrate HIV into our healthcare services and systems, into primary healthcare in more effective ways. And I think that's so crucial. Malaria work is heavily done through the primary healthcare systems. It is community health workers who have rapid diagnostic tests that see a child often coming in with a fever, and instantly making sure that they have the diagnostic test, and then if the test is positive, being able to give the medicines. TB and HIV have not been as well integrated into primary healthcare services and being able to make them work. However, HIV has been critical in testing every pregnant woman to make sure about whether they're HIV positive, and then if they're HIV positive, make sure that the care is given to the infant to prevent transfer to the newborn. But then really following through and making sure that they're integrated back into services where you're not only making sure the woman is getting the care needed, but then you've traced out where in the community the disease is being transmitted and being able to capture those links better. So those are critical areas, and it's well recognized by the Global Fund and by PEPFAR, and I see that as being very hopeful in the direction that we're going. In TB, the Stop TB partnership has really created, there's a special moment with in the G20 being led by Indonesia now, and then by India following that, where both have emphasized TB as major killers in their countries and wanting that to be a priority for financing at the global level. And the focus there has been, again, on enabling the primary healthcare capacity. And that means moving modern TB diagnostics, which is molecular diagnostic capability, to the primary healthcare clinic, less the community health worker and more the primary healthcare clinic, that's going to see someone with a cough. And when they have a cough, you should be able to test, do they have COVID, do they have TB? Often they have both. And the approach to that is also enabling what they've been testing in several countries now is portable AI, inexpensive X-ray capability that brings to that primary healthcare clinic level the ability to do X-rays read not by a radiologist, but by an AI reading that can give you the risk of TB or other conditions like pneumonia, and then follow through on that. So it's really at this granular level that you have to move down and understand where those investments go and how you make it happen. And that's where it comes to the work that both these women lead. GFF is the best kept secret in the power of capability to drive really large investments. The thing that struck me, it took me like months to figure out how you really work. But when you get into the detail, what it is that they are paying off the interest payments if a country makes an investment in their primary healthcare system to enable child and adolescent and maternal survival. And they will pay $1, pay those interest payments so that the government is incentivized to put money preferentially into those pools, and it leverages $7 for every dollar that they put in. And so it has an enormous multiplying effect on domestic worker capacity. And then the last thing I'll say about Priya's work at the Fifth is that certainly in the US, we are advocating for some early investments that are gonna be critical to healthcare workers. We have to see the financial intermediary fund succeed in the early stages. We released a white paper stating that that early on you have to get basic diagnostics and surveillance out and available, and that diagnostic capability includes capacities to at the primary health care level to pick up on illness. But probably the second really important area is a healthcare workforce investment that we are encouraging, because at the end of the day, your ability to prevent, respond, and detect and respond to an outbreak is that someone has a fever, someone has a cough, and they're coming to a primary healthcare clinic or a community health worker, and if they don't have the ability to recognize what the problem is and then test appropriately, then you have virus circulating for weeks before you actually have the ability to respond. And we now have more and more evidence that if you can detect it within 7 days of virus circulating at that very frontline healthcare worker, and then have a response that's mounted within 1 day, and then 7 days after that, a complete response with the so-called 717 metric, that will drive towards needing to put much of that PPR work in the hands of the healthcare workers.
Thank you. I very much appreciate the optimism and the for all all that we've heard, the investments that are going to go into the workforce, which brings me back to the Honorable Minister, and the question that I'm going to ask you, which is potentially a little bit unfair, is based on everything you have heard here today, do you feel that you have the support you need for your country coming, or is there more that you need, and what would that be?
Thank you. Yes, I am confident. I'm confident because USAID by Atul really know Africa, and you will remember that in his speech he always referred to experiences in Ghana, and as you may know, Burkina and Ghana has the same challenges in health, so I'm confident. Regarding GFF, it is not because I am a former liaison officer of GFF, but I really know GFF and the model of GFF, and as Atul was saying, it is a good model with the government at the driver's seat, and with the platform, with all the partners, we are sure that if we continue on this way, we are sure to address the challenges of our health system. And regarding what CDC Africa and World Bank was saying, they all know the situation in Burkina, and so I am really confident that with more fruitful dialogue, we will have more support, and I really insist on not only more resources, but more flexible resources, and so I'm confident. Thank you.
Thank you, and that's encouraging, so that's good to know. I want to take a few questions from the audience. I apologize, but the panel was so robust. I wanted to really be able to dig into some of your thoughts. But I'd love to, if there are questions. Yes. Hi, please.
Hi, should I stand up?
Please. Thank you, Susan. Who might want to take a stab at that, about putting enough investment in the health workers? Really, it's getting passed off. Atul, hot seat, go.
I'll just say we clearly are not doing enough, but it's understanding what is it that we have to do. So first of all, at a very simple level, they are not vaccinated against not just COVID, hepatitis B. We have basic vaccinations that need to be part of the picture, and we're not there. And then the ones who were vaccinated, it's been well over a year ago. And we know now that, for the next surges, the need for boosters and getting to that next stage is going to be crucial. But second, I'd say that, as powerful as that is, the most protective, and I could go on to PPE and et cetera, the most protective thing for the workers is knowledge. And in these situations, we see again and again that there may be supplies, they're not used, managers don't support their use, they don't make sure that, that people know what they need for protection and how to be successful. And so what happens is the workers flee. They just didn't come into work during surges, and especially in the low-income countries, not just Africa, but I saw it in India where I have many family, but in Asia, Latin America, when things got bad, they didn't feel they could be safe, and so they did not come, and a lot of it was a lack of knowledge about how to be successful. And so I think there's a lot we can do, again, in that, I'd look at Priya and the fifth, that this is going to be so important to the success of PPR.
Thank you. Yes, please.
Because he said it so well, I couldn't have said it that well, and the fifth is going to be really important, but I wanted to add one thing, and I'm surprised, Atul, you didn't say that.
Okay,
it's
I
the
just left it for you.
importance of high-quality data, because with well-informed and protected health workers, if we have better real-time data, and we're making huge investments into data systems that give us much more knowledge on an ongoing basis, and then there's a response to actually what health workers in the front line are reporting, which is not happening in many countries at the moment. That will make a huge difference.
Thank you. Any other questions? Yes, please.
Hi, my name is May. I represent Johnson & Johnson Foundation. So my question is really about how you're working with the education sector, because the health workers don't come from nowhere. And we know that there's lack of quality educators, and so I'm curious, how do you address that, and how do you work with the education sector?
Happy to help answer that too, if you guys don't want to.
So for us, it's very focused on based on the national priorities, investment in the education system. And so in many of the countries, you have one pediatrician, right? Or you have 2 surgeons. And so when we look at the medium to long-term priorities, this is important. And so in our investment cases and national prioritized plans, this is coming more and more as an area where governments are saying we need more investment and support, and including also more innovations in terms of maybe more regional solutions for some of these issues. And then just to highlight the importance of education, we co-finance oftentimes between health and education for the interest and the health and well-being of adolescent girls. And so keeping girls in school in combination with a whole package of SRHR-related interventions, access to family planning and all that is oftentimes our entry point for supporting the education sector.
Thank you. And you wanted to add?
Yeah, if I can just add, so this is not on the FIF because the FIF is still, it hasn't yet provided any financing. But I just wanted to share, IDA, which is the World Bank's Fund for the Poorest, has also been, very involved in this space. And just in July, just a couple of months ago, we approved a $100 million project, a regional operation for Africa CDC. And training of healthcare workers is kind of a key element of that. And one of the things that we're doing through that project is to train epidemiologists, and actually women epidemiologists, because there aren't that many women epidemiologists. They tend to be men mostly. So, training more, providing training around that, providing, public health, more generally public health training, providing training to both men and women on how to deal with the impact of pandemics on gender-based violence. So these are just some areas that this $100 million kind of landmark project is going to focus on, and we really want to kind of build on that and draw on that and see how the FIF can in the future, also provide more training, because as you said, that's a critical element.
Thank you. And I love ending on health education, because Seed Global Health, we focus on training the needed workforce that can meet the multiple pandemics, not just COVID, but HIV, TB, maternal mortality, under 5 mortality we see today. I am really sorry, but we have come to the end, but I would encourage you to come up and ask a question after. I want to thank everybody for coming today. I want to thank InterHealth, the Frontline Health Workers Coalition, Pathfinder, and all the extraordinary partners. I want to thank this incredible panel for being here to help us continue to spur action, and certainly to Dr. Alakaja for starting us off and going to keep us moving. Thank you.